Good morning. Bonjour. Ngaramtse. Salam nachu. All right. Habari za asubuhi. I believe everyone is doing great after the coffee break and that we are now energized for this interactive session. It is our warm pleasure to welcome you all to this session interactive case workshop titled From Symptoms to Systems, Teaching Health Equity Through Social Medicine. I am intern Dr. Beniti Mbazwa from the University of Global Health Equity, currently practicing at Chidehe District Hospital. And today, I am delighted to be your moderator with my friend and colleague.
Good morning, everyone. Good morning. Yes, I'm Dr. Gloria Nishimye. I am very happy to be moderating this session with Benit, and I am an alumni from UGHE in MBBS MGHD 2025, and I'm currently doing my residency here at St. Paulo's in otorhinolaryngology. So I welcome everyone in this session. I hope you feel happy and energized and ready to have some interactive discussions. So I don't know about you, Benit, but when I finished medical school at UGHE, I felt like I was very ready with the skills, the knowledge, and even the drive to make a difference in the community. But when I got there are things that I felt like I was surprised with, and every single time I wasn't ready for. When you're talking to a patient, you're telling them how to buy a medication, what that medication is going to help them. And then a patient looks at me and they tell me, "Doctor, I hear what you're telling me, but I can't afford the medication." That used to always encourage me to dig deeper into my patients and want to know what are the factors that influence them that made them come there, but which might make them come later in a different situation, which might be worse. What was your experience in your clinical practice?
I am still in my training, actually currently doing masters in health management, but I have realized that actually the hardest questions are not the one on the exam. They're actually the ones you get to think about after the consultation. So you are wondering, did I really see this person or did I see their symptoms?
Yeah, for sure. So, as some are clinicians and others work outside of the clinics, but we've all had social medicine. Even if it's the first time, we are here to tell you more about it. So that's why we wanted to have a good understanding or start from a good basis. So we thought it's important that we have a good introduction to social medicine. Don't you think so?
Oh, yes, of course. Please allow us to welcome to someone who has dedicated his work to exactly that question, Dr. Chibaka. Dr. Chibaka is a faculty member at the University of Global Health Equity in the Department of Community Health and Social Medicine. And today is going to ground us on what social medicine actually is, why it matters to be discussed in a room like this with these great minds. And Dr. Chibaka, the floor is yours.
Yes. Gloria and Benit, thank you. Thank you so much for introducing the session and introducing me. My job in this part of the session is very simple, is basically to facilitate the conversation on why and how we should teach health equity, because the question is not if we should do it or not. We have to do it, but how to do it and why we should do it, that will be the conversation that I'll be facilitating. That's my job. Your job will be to share your insight, to ask questions at a certain moment, so as we can make this conversation ours, all of us in the room. But before I start, I would like to acknowledge and share some word of gratitude for the lady on this picture. She's called Dr. Akiki. She's one of our colleagues at the University of Global Health Equity. She's been my friend for many years, my mentor as well, and my inspiration and everything that we've been doing together in community health and social medicine. Please help me to congratulate her for the great work she's been doing at UDAG. Unfortunately, she's not with us today, but she's in our hearts. Then I will ask you, for those who didn't yet connect, to connect on menti.com using that QR code. Just scan the code using your camera on your phones, tablet, or if you have a computer, you can use the digital code there. That would be very helpful for our interaction. I'll give you some seconds for those who are still connecting. We have already 23 people who joined, yet we are more than 23 in the room. Then I expect the double. Okay, let's start with this question. Which of the following factors has the greatest impact on health? That's the question we have all to answer on menti.com. And we'll be seeing the result live and then discuss about our findings. The technical team, can you just remove that small video there? Yes, thank you. It's interesting. It seems that you've been already reading before you joined this session, because the findings that we are seeing here reflect the current data on the determinant of health. In fact, the major part of this pie is social factors, as you can see. And the least is the genes and biology. Let me show you another pie, similar to this one, but from the literature. It looks like this. Health outcomes are shaped predominantly by non-medical factors, mainly social factors. Only a small portion of the pie is the genes and the biology factors. Yet, when you look at the time we spend at the medical school, we put a lot of emphasis, and that is right, on the genes and the biology aspect of health. That is okay. But what do we do about the social factors? Question mark. And we'll discuss more about it. But you can see that medical care itself, everything related to health services, the health system functioning, how we are taking care of patients, represent 15% of the pie of the factors that influence health or ill health. I can also say behavioral factors represent 20%, very important factors and determinant of health. Now, what are those social factors that we are talking about? Please answer on Menti. Any idea you have, please share there. If you can share at least one factor, you've done your job. I can see poverty. I can see finances, nutrition, political systems. What else? Income, transportation, housing, religion, beliefs, living conditions, money, homeless, relationship, environment, stigma, ignorance, equity, conflict. The background, the context, the climate and climate change. Keep going, because there are many factors indeed. political crisis, water, lack of access. And thank you, by the way, for helping me to build this slide. And I hope that you'll allow me to use what you are sharing here for the future generations that will be teaching. Early childhood development, housing, and so on. Everything you just mentioned there are what we called social determinant of health, and they are defined by WHO as the conditions in which people are born, grow, live, work, and age, and that shape their health and well-being. I think that is a definition that we all know. And you've shared more than actually what I was able to prepare there. Thank you so much. The thing is that those factors drive inequities in health. And addressing the inequities is essential for health equity. Let me share a story of mine when I was still a medical student 20 years ago. That was the time when I was learning to find what is wrong with the patient, the diagnosis. And the first step is to unveil the history. Which history? They told me it's the history of the disease. I asked about the main complaints. I asked about what are the symptoms, the onset of the symptoms, the duration of the symptoms, the associated symptoms. It was all about the history of the disease. And interestingly, they also added that patients tend to talk too much about their life. They tend to talk too much about how they were visiting that aunt, ate some food there, and they think that the GI problems they are having is probably coming from that aunt. They told me that that part of the history that the patient is telling, just make sure to ignore it. Bring back the patient to the history of the disease, because that is your job. That's how I was trained, and I guess that some of you who are old enough can relate to that story. I was trained actually to stop the patient, to interrupt them when they start deviating from the history of the disease, to bring them back to the actually what is wrong with them, the disease, the biomedical aspect, because that's what has been trained to unveil, not just the patient history, the history of their life, their narrative, their fears, their feelings, their expectations. No, that was not my business. And that's the way I was trained until I went through my residency in family medicine. That's when I realized how wrong my training was. Then the question to all of us is it possible to teach future healthcare providers, medical doctors, to ask questions about the two histories, the history of the disease, but also the history of the patient? Is it possible? I believe, yes, it's possible. We can do that. Then, that's what social medicine is about. And I want first to check what you know already about social medicine. When you hear the term social medicine, what comes first into your mind? Please share. Community, you're right. Holistic care, comprehensive care, you're right. Accompaniment, accompanying the patient in their journey, the journey of their life, not only of the disease. Health activism, definitely. Holistic care. Society, yes, it's a new buzzword, but it's very old, as you'll see. Empathy, I can also say compassion. Living conditions, definitely. Health activism, we said it already. Social determinant of health is a key word in social medicine. Paul Farmer, of course, another mentor of many in the room. psychology, definitely, social status, economic status, person-centered. I can also add community-centered as well. Social habits, culture, politics, which is one of the hidden factors, but very powerful force. The culture, and I have some interesting stories about our cultures in Africa. Let's move, and thank you for sharing what you think about social medicine. Everything is correct, I believe. Now, I'm sharing this disturbing picture. It's an AI-generated image. It's not the reality, or maybe it can be the reality. We'll see that. My question to you is, when you analyze this picture, and this is a very different perspective of seeing social medicine as well, what do you think, or why that person there, probably a health professional, nurse, medical doctor, yeah, social worker maybe, why are they working upstream? Why? That's the question, and I want to hear from one of you in the room. Can we just give the mic? Indeed, a disturbing picture, but it may reflect the sad reality as well. The one at the front here, front, it's fine. Yeah.
Thank you. The health worker is not mining of what is down. It's trying to go upstream to find the root cause, what is happening and what is making this. And this is the social determinant of health. You need to
Yes.
go back
Yeah.
and see what is in our community. Thank you.
Thank you so much. What is your name, if I may ask?
Ojara Sunday is my name from
Odera,
Gulu.
thank you so much. Yeah. You are exactly right. That person is trying to figure out why people are falling into the river. Medicine actually try to understand what is happening downstream at that level. And medicine, or should I say the biomedical model of medicine, help us to understand what is happening just on the picture, what we are seeing there, and how to address it at this level, downstream the river. Social medicine help us to ask and answer the question, why people keep falling into the river? And most importantly, what can we do to stop that? That is another aspect of social medicine to keep in mind. This is one of the many definitions of social medicine. It says social medicine examines how social, economic, political, historical, cultural, environmental conditions, and the many other conditions that you share shape health, illness, and healthcare. And again, very important, and how health professionals can act on those realities. The question is that, do we teach health professionals, do we teach future medical doctors to act on those realities, especially those realities, those factors, those forces that are driving inequities, that are driving injustice? Do we really teach them? Question mark. At some point, we'll have to answer that question. Let's move. Let me share a bit of history of social medicine. When you navigate through the literature, it says that the father of social medicine is, can someone mention the name of that person? Who is the father of social medicine? He is also the father of public health. He's also the father of pathology, if I'm not mistaken. Who is that person? In the room, an answer? Who is that person? Yes, I heard someone mentioning Virchow. Rudolf Virchow is actually, at least in the books, the literature, the father of social medicine, and this is since 1848. Virchow was a physician, pathologist, anthropologist, and politician. He was many in one person. But a point that I want to make here and that many are now making is maybe it's time to shift from that European genesis of social medicine and start seeing it from a global perspective. Indeed, in all our communities, traditional communities, in all corners of the globe, we've been practicing some kind of social medicine. Maybe we didn't call it social medicine, but it was social medicine. Let me give an example that I learned when I was still a kid. In my village, people knew already that there was a connection between climate, weather, between a long dry season with poor harvest, with starvation, with food insecurity, with malnutrition, with high mortality among the children. They knew that already. And that was already social medicine. And they knew what to do. They knew, for example, that they need to pray for the ancestors, pray for the nature, to be clement, to really forgive all the sins, so as the nature can be more generous to us. They knew that. It's social medicine. But at a more scientific level, in Africa also, we developed social medicine models. One of them is what we call the COPC model that was developed in South Africa in a small village called Folela in the 1940s. That is a model that actually started pushing healthcare providers to not only focus on addressing the individual health issues. It was clear that to fix what is wrong with health, we need also to focus on what is happening in the community. That was already in Africa. Then came the movement in Latin America, the movement of health equity, social justice, health as a human right. Then Alma Ata in 1978, the Alma Ata Declaration that insisted on primary health care as the foundation of the health system, the health care, especially if you want to reach what they used to call health for all, what we may call now health equity. Then moving forward, more recently, we had WHO that put in place a commission in 2008 to examine the status of social determinant of health in relation to health outcomes, mortality, morbidity. And one of their conclusion and observation was that social injustice continues to kill on a grand scale in both high and low income countries, as the world fails to tackle the root causes of ill health. At that time, their conclusion was that we are failing to tackle the root causes, and we may ask ourselves, especially as educators, policymakers in the room, why? Then moving again forward in 2025, they basically repeat the same study. And that's his last year, by the way. And the conclusion was basically the same. People are dying because of health inequities. Yet health inequities are not inevitable. They are evitable. They are socially produced, they are politically determined, and therefore preventable through action on social determinant of health equity. You can see now the nuance here. They are no longer talking about social determinant of health. They are really insisting now that we should think about social determinant of health equity, because that would make a big difference. Moving forward, or maybe before that, for those who want to learn more about the global histories of social medicine, different case studies have been put together in this book and reflections. The book is called Medicine on a Larger Scale. Actually, that comes from Virchow, but they try to open up that history of social medicine to the globe. Now, quickly, let's talk about why and how we can integrate social medicine into medical education. First, why do we need to do that? There are many reasons. I tried to put there 6 of them. We said already that health is shaped by modern biology, but do we teach students the non-biological factors, what they are, how they work, and how to address those that are driving inequities? Do we do that? No, we need to do that. That's the reason, one reason why we need to integrate social medicine, because social medicine can also help to improve the quality of equity of care quality, because we are now suddenly seeing not only organs, we are seeing human beings, we are seeing communities. And our students need to learn that. They need to be equipped as future doctors, healthcare providers, and be ready to deliver care that is person-centered, you said it, community-centered. It's care that is holistic, you said it, comprehensive. It's all about rehumanizing health. I'm sorry, because during these 3 days, we've been talking a lot about how to leverage technology, digital technology innovations. But for me, this is one of the neglected innovation. It's not technological. We may also use technology, definitely. We need to rehumanize healthcare. If we don't do that, whatever technology, which are just tools we bring, will not really help us to solve the issue of poor health, ill health. And then there are other reasons. I'll simply cite them for the sake of time. Social medicine helps us to prepare physicians that are change agent, that are ready to work with the community as partner, not as didactic material. It's very important to also nuance that. It also helps us to better prepare cadres who are ready to work in the messy world, the messy communities, societies that we have, the very complex settings that we practice in. And of course, aligning with normative institutions like WHO, it's very important for us to align with the global and our institutional missions. I'm sure that in our institution missions, most of us, we have somewhere where we write social accountability. But how do we put it in action? Social medicine can contribute to that. Then quickly, is social medicine integrated in your medical curriculum? Yes, no, maybe you don't know. Please answer quickly that question. Don't be shy. This is supposed to be a candid conversation. Just share, because we'll get a sense of what we need to do together next. So far, most people who have responded are saying yes, and I love that. Which means that we really align on this. We still have a number of people who think that they don't. We can work together to make sure that you also integrate social medicine into your medical curriculum the way we did with UGHE. We went through that process. I wouldn't go through that. This could be something we could discuss later about, and how we teach social medicine from the classroom, where students learn about the foundations, principles, theories that guide the practice of social medicine, where they learn also how to practice those skills like, we've been talking a lot about critical thinking. We've been talking about how to do a equity analysis, how to develop those human skills that are very important, like compassion, like humility. They learn that through simulation. Better, they learn that through immersion into the community. We have a whole program called Community-Based Education program that help on that. And reflection, and one of the simulation sessions that we'll have now in this room will be about that reflection part of how we teach social medicine. We also believe in the feedback we get from our community, the knowledge we get from the community. We call it shared mastery. We have something, our students have something to bring to the community, but they also have a lot to learn. It's shared mastery. And that's how we believe we can train students who are ready to practice as very good clinicians, but also cadres who understand health at a very system level and ready to act and change things. Just to wrap up and finalize, I'll leave you with these words. Every disease has a biology. That has been our focus as a medical student. Every patient has a story. Every story has a social context. Now, medical education should prepare graduates to understand and act on all three, not one of them, all three of them. Medical education should prepare graduates who are compassionate, who are working with humility, who are putting the community at the center, who are ready to promote equity, justice, and social accountability. Thank you so much. I will leave you with this beautiful picture of our campus, the UGH campus, which is intentionally built in a very remote rural area in Rwanda. And I will also leave you with this quote from the Partners in Health co-founder, who is also the founder of UGH and the first chancellor, who passed away a few years ago. And one of his famous quotes says, "The idea that some lives matter less is the root of all that is wrong with the world." The idea that some lives matter less is the root of all that is wrong with the world. I will leave this quote for your reflection. If you want to read more about social medicine and global health equity, I've put also some references and many from Dr. Paul Farmer, who has been actually one of the prominent scientists in social medicine and health equity. Thank you so much.
Thank you very much, Dr. Chobaka. So after this grounding session that gives us all a same understanding about social medicine, I'm going to take you with me to a session that I used to enjoy in community-based training. We're going to see a session right now of students with their facilitator and a nurse that are going to be reflecting after a clinical day. So I want you to follow and also be attentive to what they're going to diagnose, but not only that, what they're going to decide to do after having that discussion. And I hope you learn a lot and be able to comment later. Thank you very much.
Hello, how are you? Are you all doing well? I'm very happy to reconnect with you. I want to hear from you how your day went. I just told you this is fourth module of your CB curriculum, and it's really great pleasure to expose you to social medicine in primary health care delivery. We are going to discuss, to reconnect, and to reflect in the service where you have been assigned today. And I'm glad we are with our head of health center, Diane, who dedicated his time, her time, really to reflect on the case and to move forward on how we could alleviate this social medicine case you've been working with. So we are going to start with Benit, Jocelyn, and Pascaline, and then Diane will guide us. Thank you.
Thank you so much, Prof. Dennis. So with the reflection of my today's work, I was in the IMCI clinic today and I worked with Nurse Sophia and we saw a total of 10 children. So these children, most of them, they were presenting with flu and intestinal worms. But really, what stood out the most for me is a case of Eve. Eve is a 3 years old patient who presented with diarrhea and abdominal pain. And upon further assessment of this patient, we came to figure out that he had symptoms of severe acute malnutrition. So this patient really was very ill, but also seeing the caregiver who was accompanying him was something that makes me sad because the woman who was with him was much older to be his mother. So I went on and tried to ask really about his symptoms and the caretaker. And this woman turned out to be his grandmother. So I was really thinking, okay, this is a very young child who is in his age where he should be with his parents, but he was not with his parents. And from what I saw from the woman, she looked really tired and her feet were filled with dust. And I was wondering, and I asked the woman, how long did it take you to get here? Because they really looked tired. And she said, we used 2 hours and we walked by feet. And that made me wonder about Eve and his home, like where do they live, what conditions are they living in. And I really would like to know more about this patient and his malnutrition, because I am really concerned that if we end up giving medications, given his conditions and the fact that he was with his grandmother, if we are not knowing the root cause, how will we know like if the medications are going to work after all? Yeah.
Wow, you did it, Benita, and it is really great. And it is a heart-touching story, as it reminds me so many other stories of other babies who are born from single mothers, especially those who are teen mothers, and they used to be left behind with no one to take care of them. But life is like that, and they are suffering a lot in the community. At least, did you mind or did you manage to investigate why this Eve is having diarrhea?
So thank you, Nasdian. From our conversations with the patient, of course, we moved on and did some assessments, and we also did some lab tests. And from his diarrhea, we ended up finding that this kid was suffering from amoebiasis. And after that, we prescribed some medications and treated his diarrhea. But for me, I'm not really convinced that this should be the end of this patient's care.
Of course, you did well, and congratulations as you find out that this baby is having amoebiasis. But Benita, treating amoebiasis with those prescribed medication, I can tell that it is not enough for this baby to be cured. As you said, he's suffering from malnutrition, and malnutrition can be like malnutrition alone. So we need to investigate more. We need to go to the community. We need to assess the water access for him, the food, nutrition, and security issues that he's living in, the condition issues. Most especially, don't forget about the hygiene. Not so? Can we move for the next presenter, please?
Thank you so much, Nurse Diane, and thank you, Benita, for sharing about your patient. For me today, I was working at the antenatal care unit, and today I was working with Nurse Elizabeth. We were able to receive 15 clients, and among the clients we had one specific woman really stood out to me, and her name was Miss Rachel. So Madame Rachel, when she entered the consultation room, she was more concerned instead of being excited. As a pregnant woman who is coming for her appointment, I was expecting that she was going to be more happier and excited, but she was really sad and concerned. So we asked for more information about what was happening, and she explained to me that this was her third pregnancy, and unfortunately, her previous two pregnancies ended up being lost, so she was unable to have her previous two babies. So she was very sad and concerned that maybe perhaps this pregnancy was going to end up being the same as well. And I really took this at heart, and I would like to advocate that we can consider visiting Madame Rachel during our social medicine visits, especially because other than helping her at the health center with the appointments, I need to understand her story, and we find ways to support her towards having a healthy pregnancy. And I hope Prof. Dennis and Nastian can take this into consideration. Thank you.
Well, Jocelyn, I can say that this is a heartbreak story. A loss of two previous pregnancies. My dear friend, this word is very tough. So, as you know, the loss of pregnancy can't go alone, and it is basically based on clinical conditions and other non-clinical conditions. But the community out there, they are thinking of witchcraft, most especially, but think how this lady is feeling and how community is treating her. It is very hard. And get to know that among non-clinical conditions that can expose this lady to this loss of successful or these abortions or loss of pregnancies may include her living conditions, stress management, family conflict, nutritional status, and so on. So we may investigate more, we may pay her a visit, and you may go deeper and beyond these clinical conditions only, so that we may investigate more and get to know how we are going to help her and how we are going to sustain this lucky of her of getting another pregnancy. Please, how are you?
Thank you very much.
How
I'm
was
doing
your
fine.
day?
My day today, it was, I wouldn't say it was a very good, I would say it was a very good day. I worked with Nurse Rosette. I was in maternity service. We only received 4 women to delivered successfully, and the other 2 are still in labor. What stood out for me is realizing how the significance of financial capacity. It is very important for women to be covered when it comes to delivery and also their pregnancy. And what I saw today firsthand is that most women who come at the health center, they don't like have the main needs or the items which are necessary for them for during delivery, and also which can help to cover their babies. And this made me realize that it is very important for women who are pregnant and who are going to go through delivery to have a greater social support. And also a case that stood out for me as well is this woman who is called Anualit. In my usual experience is when women are having their babies, they are very happy, very excited. However, Anualit, she could barely look at her baby. And when I caught her eye, she directly looked away. And then I told myself, why not approach her and ask her what's going on? And when I tried to have a conversation, she started tearing up. That's when I told Nas Rosette to come with me and make sure that we have like a brief conversation with her. And then we concluded that she would need like a counseling session before she could go home. Thinking to myself, I was telling myself that maybe I didn't do enough, but making sure that she gets the support that's needed was the least I could do. So then we we gave her a referral to our mental health service here at the health center, and I made sure I had to accompany her and do the follow-up as well. Thank you.
Wow, 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 wow. Mental health matters. Congratulations, my dear. As you link this client to the mental health services, it is a great support, and it is a very big contribution as advocacy is our daily basis and it is our routine care that we have to offer to the client. Then, congratulations, you all. You did well. You may clap for yourselves. Now, yes, good. We are moving to the next level of our sessions for today. We are going to decide. It is not only clinics that we are doing, then we are going to decide how we are going to manage and arrange our community descent. Aren't you excited? Then you are going to motivate your ideas. You are going to choose among these 3 cases that you presented so that we will know which family we are going to pay a visit. But of course, we have to link the biopsychosocial model, and also we have to be based on the principles of healthy equity, patient accompaniment, and social determinant of health, of course. Are you sure? Then go on.
So thank you, Nastian, and thank you to Jocelyn and Pascaline for your patients and cases. So for me, I would like to advocate for Eve because Eve is 3 years old. He still has a life, a big life ahead of him. And from our class, you remember how we learned that malnutrition can affect not only like the physical growth, but also the mental and the social aspects as well. And my concern is if we focus on giving medications only for Eve, and maybe at home he will not be able to take these medications, or even if he is able to afford, maybe he does not have the food, or there are other factors that has led to him presenting with malnutrition in the first place, then we're treating him like we're giving him half treatment. So for me, I strongly advocate and feel like we can do home visit for Eve to know more what's going on with his life and to really dig deep into knowing like about why he was also accompanied by his grandmother. Where are his parents? Does he have siblings? And things like that. So yes, Eve.
Thank you, Benita, for sharing about your case. I do acknowledge and understand that the case of Eve is really concerning, given that he's a young child with malnutrition. But I would like to also advocate for Madame Rachel, the patient I told you about earlier. Given her condition too, given the fact that she has already lost her 2 previous pregnancies, and unfortunately there have not been any identified medical or social cause for her. Her entering the OPD and explaining to us her condition, I really felt a sense of responsibility to follow up on this case. I feel like it would really mean a lot to Madame Rachel and her family if we follow up on this case and ensure that we know what's causing her to lose pregnancies, but also ensure that she has a healthy pregnancy for this time. I would strongly advocate that Prof. Dennis and Nurse Diane can put that into consideration as well. Thank you.
Thank you all for sharing your experiences today. I also agree with you both. Eve and Rachel, they need our attention, but in my opinion, I think Rachel Rachel needs like close follow-up and also making sure that this time she gets like a healthy delivery. And from the experience that I've had in maternity, I've seen that it can benefit people's family and make sure that it also improves her livelihood. Yeah, thank you.
Wow. Eve and Rachel, this is fire. Then we are going to decide based on equity and critical thinking, of course. Mr. Dennis, what if we choose Rachel first? I remember we have 2 weeks for this period. Then we can start for Rachel this week. Tomorrow, I think, is the next session. Then by the next week, we can pay a visit to Eve. Is that fair for you? Okay, thank you very much. Before I forget, I have a homework for you. Take your pen and your notebooks. Tonight, you are going to read through human security issues. Human security issues. And remember that you are going to present this topic in front of the whole team of this health center. They are going to discuss and they are going to exchange ideas. And of course, this will help you to know what you are going to do and what you are going to contribute to our community, especially to these two cases that you are choosing. Thank you very much, Mr. Dennis.
Thank you very much, Diane, and my students. You are making me proud, really. I want to congratulate and really salute, commend the work of Diane, isn't it? She's really a great supporter of our university, and it's not for nothing they are our community faculty. They are integral part of UGHE product faculty. So as you concluded, tomorrow we are going to visit Madame Rachel with Jocelyn, and Benit, you are going to be with Jocelyn to prepare the case, to prepare the visit, and then, or as always, Diane is going to help us to link you with whoever you want, whether in the community, local leadership. Feel free to reach out. You have her number, you have my number. Even if we come back, the time we came back in campus, you could have like some questions. Feel free to ask, to make sure that the visit will be well conducted tomorrow. And also, we still have 2 weeks in the health facility. Feel free if you want to visit other cases you want to visit, Eve for malnutrition, and the other one for Pascaline. Feel free to reach out, Diane. We can arrange your visit, and tomorrow morning you are going to be in your respective service, and then afternoon 2 p.m. we are going to conduct the visit. Is it okay? Thank you very much. Keep preparing your assignment. So we meet tomorrow morning, and then early morning we'll start on presentation, and then your service. Afternoon we will visit Madame Rachel. Are you okay, Jocelyn? No question? Thank you, Diane. Thank you very much.
Thank you very much, Dennis. And I'm going to organize the whole team. And thank you very much for the audience, for your good attention. And this is what we conducted at the level of health center. Thank you.
Thank you very much. This is what a debrief session typically looks like at the level of the health center. That was in Burera district, Northern Province. What we just witnessed is that Jocelyn shared about Rachel. And she wants to go and understand her world. And that is what we're going to see. So we're already tomorrow, right? Good morning, good evening, good night, good morning. Okay, so we are the next day. So the next day, they did go. And Rachel actually was visited. Here, we are going to see what she said after the visit. So let us all please watch her testimony.
Nyamara gushaka byari bigoye cyane, njyewe igihe cyo kubura urubyaro byari bikomeye, umutima wanjye wenda nko gusandara, nanjye nkiheba nkagira agahinda, byarakomeje inda ya kabiri ivamo, nabwo kwiheba bibwo amarira yari menshi.
So I was fortunate enough to meet Rachel sometime last year in my second last CBT module, where I was shadowing an antenatal care nurse, and she had come in for her third pregnancy. I was really interested to see, like, okay, how can we make this a reality that Rachel becomes a mother, because she really wanted to be a mother, and at the same time see and meet these community members and see where all of this happens, where she's able to get support and having that strength and courage to go on and have more children.
Inda ya gatatu nibwo yagiyemo bibaho, naje guhura na Jennifer ku bitaro.
So she was a G3 para0, meaning this was her third pregnancy, but she didn't have a child at home as a result of having 2 miscarriages. And this was because her and her husband had 2 different blood types that resulted in this sort of disorder called rhesus incompatibility. And this is totally preventable in the current modern day world of medicine because we have anti-D immunoglobulin and they're readily available, and pregnant mothers are able to take it at 28 weeks of pregnancy. But in her case, whenever she was referred to district hospitals or referrals, it was either the specialist was not available or the shot was not available for her to take at the time, which is very, very sad and resulted in these 2 miscarriages.
igihe kigeze naragiye mbyarira ku bitaro bitoya kuva icyo gihe narishimye cyane nahise mbwira umuganga ati si muganga mbyaye umwana muzima arambwira ati ubyaye umwana muzima nararize ibyishimo birandenga kuko nari mbonye umwana urugendo naciyemo n'ibibazo nagize nahise byibagirwa.
I didn't realize how strong or powerful, I should say, small actions are, because simply following up on Rachel resulted in her having a baby. Simply enabling her to go to the right hospital at the right time to get what she needed made such an impactful change to the point she became what she always wanted to be, and that was a mother.
Abanyeshuri ba kaminuza ikintu bakoze icya mbere cyangiriye akamaro cyane ni uko bampumurije bakanyereka ko bibaho mbese bakamba hafi nibo bangaruriye icyizere mbese kubona umwana no kubona umwana mbese navango nabo babigizemo uruhare.
This was a very powerful message. And I would like to remind you that this is a real scenario. This Rachel that you're seeing exists. Jennifer is a student at the University of Global Health Equity. All the students that you saw in this video, they are students. Some of them are us, and some of them are students in other cohorts. But this is a real scenario, a real story of what happened at UGHA. So I would like to thank very much our doctors that demonstrated the case of the reflection. And as they stand up and greet you, you're going to give them a round of applause, starting with Dr. Jocelyn Zisabira. She's a UGHC alumni, and she's also doing her clinical oncology at Addis Ababa University. Also with Dr. Benita Uera Bernadette, also a UGHC alumni doing ophthalmology at St. Paul's Hospital. And then Dr. Pascaline Sanzurguanda, who is also doing ophthalmology at Addis Ababa University. So thank you very much for your reflection.
Not forgetting our facilitators, Mr. Denis Dangurura, a UGHC faculty member who trains us to think beyond what the symptoms of the patients and really, really helps us in our community-based training. And Ms. Diane Iradukunda, the head of Ndongozi Health Center in Burera district in the northern part of Rwanda, and they're also our community teachers. Thank you very much.
So we are going to open this to discussion for everyone in this room to have a contribution. And as we open this to discussion, we are going to start with 4 very important people in this room and who have really contributed to this space of social medicine. I'm going to start with a person whose research has really changed what we understand that universities owe to the communities that they serve. So we're going to start with Professor Lionel Green Thompson. Professor Lionel Green Thompson is the dean. So he's the Dean of the Faculty of Health Sciences at the University of Cape Town. He's a specialist anesthesiologist. And his PhD work has examined social accountability in South African medical education and practice. Recently, he was awarded the 2026 Charles Boylan International Social Accountability Medical Dean's Reward, and he currently serves as the executive of COMSA and the Network Towards Unity for Health. Professor Thompson, please rise. So, as a person who has shaped what accountability is in health professions education, I would like to ask you, how do you see the relationship between social accountability and social medicine, and what will it take for medical schools to meaningfully integrate both in practice but also in education?
Thanks very much for that question. Let me just define social accountability first, as the literature describes it. It's this idea that those of us who train health professionals should make sure that what we're doing is responsive to the needs of communities, whether we're doing it in research, service, or education. And so that's the key part of social accountability, is that the community becomes an equal partner to all of the partners in the process of education. But in preparing for today, I began to reflect on how we think through this connection between social accountability and social medicine. And I was quite struck by the introductory remarks where I hadn't realized that Breakout is regarded as the father of public health. Because in my remarks today, what I was going to say is that if you look at Breakout, most of us remember him because of Breakout's triad of the way you get a deep vein thrombosis is because you have an endothelial injury, you have stasis of the blood, and the blood is hypercoagulable. And then he says at another time of his life, he says, the physician occurs as a natural advocate for the poor. And for me, that's the link, right? Is that the minute you think about your social accountability, you have to think about who you're accountable to. And if you become an advocate for people, then you're accountable to the people. But importantly, I think if you're thinking about the curriculum, for me, it's a key thing. And I think what you've demonstrated so powerfully in your case presentations today is that nobody denied that she had a medical problem. The medical problem has to be dealt with. But I think what social medicine says to us is that we've got to be cautious that we focus only on cure. We focus on the fact that something has happened within the context of a community. And I think that's the connection, right? Is that social medicine asks us to see the whole person in a whole community, in a whole region or context that they come from. They're not only their disease. And so in the way these cases played out today, it's, yes, they have a problem, but there are other things behind the problem that make them better or worse or facilitate their cure and prevention of them happening again. So when you asked about putting them into the curriculum, I think we've got to accept that it's ordinary conversations such as these. We may have to decide how much cure we do and what the role of health professional is in prevention. Because then I think that's where the community comes in along. But unfortunately, the way we structure our programs now is that we really emphasize cure. And we've got to shift a little bit and take out some stuff and put in the social medicine aspect. Because I think that's the key thing. We can't just add social medicine. We've got to start recognizing that people are not their disease. People are people, and then they come with a problem. So for me, it's about looking for spaces across the curriculum about where we can do this. In our surgery department, for instance, at the moment, even the students who learn their surgery at a high-tech surgical unit have a session discussing about how surgical systems work across the country. Because they're integral, they can't be separated. Thanks.
Thank you very much, Professor Rionel. And it is true, like patients are not the diseases. They're just people who come with problems. Let us now welcome Professor Risenga. Professor Risenga, the Dean of School of Medicine at Stefako McGattle Health Sciences University, SMU. He trained as a cardiothoracic specialist surgeon and is an experienced clinical specialist and head of cardiothoracic surgery. He's trained in teaching medical educators. He's a recent past president of South African Medical Association, bringing both institutional leadership and frontline clinical experience to the conversation on embedding social medicine across university curricula. Good morning, Professor Senga.
Thank you very much, and thanks for that kind introduction.
Professor Isanga, as a surgeon and academic leader, you have experienced the demands of producing graduates who are both excellent in clinical care, but also in the service to society. So I would like to ask you, how can medical schools better integrate social medicine into clinical training so that future physicians deliver high quality, equitable, and socially responsive care, and what institutional changes are needed to make this a reality?
Thank you very much. I think the earlier morning lecture or this afternoon lecture when we started, and the demonstration from colleagues in the stage answers that question. And I think it was well done. I think we must remember that health happens outside of the health system. So as we're speaking, health is happening out there. Before we see these patients coming to us, health has happened. So in my reflection, trying to answer that question, I also thought of what is social justice in health? And it was eloquently put that social justice really is advocacy. One of them, because it's from a use of income, cost to come to the hospital, and so on and so forth. By the time they present, it's late, they are on stage 4 lung cancer. As opposed to a patient who's from a rich background, who can be screened early, who can then get diagnosis early, be operated early, and therefore stand the chance of being healed. That's a social determinant of health. So we must teach our students that what are the underlying social, economic, structural factors producing these differences. And in our curriculum, therefore, we must think about what do our societies deserve. Our societies deserve well-educated and trained health workforce that understand these nuances or differences. Higher education institutions should have the accountability accountable to society and to be accountable to regulators. And there must be equal standards of training across health institutions. Because social cohesion being undermined by multi-generational privileges of the rich and of the poor must be taken into account all the time. So as medical schools, we must learn to integrate medicine into curriculum, not as an isolated module, but as a longitudinal thread throughout medical training. In our institution, we have a program called Practice of Medicine, and we start teaching our students basically from when they come in the first year, almost the same as what we have seen demonstrated here. So social history, as you said, Prof, it's very important that the students understand this. So what about institutional change? What must we do as an institution to make sure that this social justice or social medicine is inculcated in our curriculum? I'll just mention 6 things. 1, we must make our curriculum be explicit to include social accountability, social justice, and health equity, and part of our graduate attributes and learning outcomes. If we say these competencies are important, then we must teach them, assess them, and measure them. Health equity, social determinants of health, and social responsive clinical decision-making must therefore be incorporated into our OSCEs, case presentations, portfolios, and work-based assessments. We as medical schools must then strengthen longitudinal exposure to primary healthcare districts, hospitals, rural communities, and underprivileged communities. We must also invest in our faculty, because most of the time our faculty do not understand, especially specialists, this issue of social medicine. We are too specialized to understand that we must go up the river to catch the patients before they fall into the river. But most of all, the important thing is also we must bring the community in. We have all the time been saying that students have got voice in our curriculum. But it's high time that we must get the communities have a voice in our curriculum as well. There's an adage that says nothing without us, nothing about us without us. So it's important that we get the community part of the way we develop and structure our curriculum. So the sixth one is institutional leadership. That must be prepared to measure health equity as an educational and social accountability outcome. We should therefore examine where our graduates practice, which populations they serve, whether they remain in underserved areas, and whether our education programs contribute to reducing health disparities. So I think integrating social medicine into clinical training requires a shift in mindset from teaching students only to recognize symptoms and diseases, as was eloquently demonstrated here, to helping them understand the systems and social conditions that produce those diseases. That for me is that intersection of social justice, health equity, and clinical excellence. I think.
Thank you very much, Professor Isenga. And with the practical ways of involving social medicine in different curriculums, that was very powerful. Thank you very much. So next, I'm going to address Prof. Rahel. And Prof. Rahel is an assistant professor of pediatrics and child health at Addis Ababa University, where she also served as a pediatrician and clinical director. She is president of the Ethiopian Thoracic Society and serves as vice president for communication partnership at Addis Ababa University. And she brings perspective grounded in both clinics and medical education in the Ethiopian context. Professor Rahel. So Professor Rahel, being a clinician, but also a leader who's worked in different fields involving research, systems strengthening, but also health education, I would like to ask you from your perspective, how can social medicine equip future health professionals to address the real health priorities of communities, and what institutional changes are needed to make this vision a reality?
Okay, thank you. It's really a privilege to share my views on this important topic. As a pediatrician, in all fairness, I have to say that we were taught early on to look into the social determinants of diseases in our history. We are always include, the housing conditions, hygiene, even development, and the like. So we were more taught to look into the prevention part of it, not just curative part of a disease. So I think this topic is close to my heart. It's quite important. So having said that, institutionalizing social medicine within universities or any medical education frameworks, it needs a structured framework that begins with strong inputs, such as faculty experts, public health, ethics, maybe social medicine experts, partnership with ministries and community organizations. Resources because it needs to mobilize resources for this community-based rotation and participatory researches and clear institutional commitment to equity. To make this vision a reality, it has been mentioned by my other speakers as well. Curricula should embed community-based learning and interprofessional collaboration, so students experience firsthand, challenges that face outside hospitals. Several African medical schools and health institutions are embedding social medicine into their curricula through competency-based educations, community-oriented trainings, and simulation-based learning. I think this is done in Cape Town University as well. For instance, in our School of Medicine, integrates in its curricula community placements, where students live and work in rural or underprivileged areas. The other issue is, as a mission, we do, we conduct researches. So I believe that research agendas must shift toward applied, community-oriented studies that inform policies and practices. This designing, community-based researches that incorporates social medicine principles. It requires, a holistic and participatory environment. It begins engaging local stakeholders, the community leaders, the communities in defining actually the problem, the challenges, followed by interdisciplinary collaboration across sectors, maybe as health, education, and agriculture, to address these questions. Employers should researchers should employ, participatory methods, and capacity building must be done as well. It's very central, with students and local health workers trained in research ethics and advocacy to strengthen health systems. I see technology as an enabler. We have seen, and we have, it has been mentioned as a dehumanizing future, but yes, but we still need to use technology because it plays a transformative role in advancing social medicine, in enabling interactive, accessible, and data-driven learning experience for students. Together, this innovation not only modernize pedagogy, but it also prepare future health professionals to address societal health needs with greater empathy, efficiency, and evidence-based strategies. So I believe that technology should be actually integrated in our education systems. Universities also need to culture this, social accountability, where success is not measured just not by publications, but actually by tangible improvement in the community health outcomes. This entails regular dialogue with communities to identify pressing health concerns, integrate participatory research that I have mentioned before, and foster interprofessional collaboration across sectors like health, education, and agriculture. This cannot be done in silos. We need to have partners collaborate. And this will bring, together diverse expertise, resources, perspectives that enrich both the curriculum and student learnings. Collaboration between universities, healthcare institutions, community organizations, and government agencies create opportunities for experiential learning, allowing students to engage directly with real-world public health challenges. Moreover, joint initiatives enhance, research capacities, promote innovations in teaching methods, and ensure that educational programs remain responsive to community needs. This, in the future, will also foster this collaboration, intersectoral collaboration, as it is essential for addressing complex health development challenges that extend beyond the capacity of any single institutions. I would love to mention one of the flagship, initiative of our country, which is a school feeding initiative. For instance, this requires coordination between Ministry of Health, Education, and Agriculture to ensure children receive nutritious meal, improve learning outcomes, and support local farmers. Such collaborations actually fosters equity, strengthens systems, and ensures that reforms in access and quality are sustainable. So we need to partner, collaborate between institutions. Case in point, this kind of initiative, flagship initiative, it actually has a positive impact in both learning outcomes and health outcomes, are demonstrations where we can base our education on. Having said that, I believe that social medicine becomes a bridge between education, research, and service, preparing health professionals to act as both clinicians and advocates, ensuring compassionate care, and remain responsive to the real priorities of the people they serve. Thank you very much for the opportunity.
Thank you very much, Professor Rahel. And indeed, research needs to not to end with publications, but actually see how it is impacting the community. Now it is my pleasure to welcome Professor Phil Cotton. Professor Phil Cotton is the Vice Chancellor of the University of Global Health Equity, a family medicine physician, and a global leader in health professions education. A dual British Rwandan citizen, he founded Rwanda's first medical school, led the University of Rwanda as Vice Chancellor, and has dedicated his career to building equitable, community-centered health education systems across Africa. He's a fellow of the Royal Society of Edinburgh and recipient of the ASME Gold Medal for outstanding contribution to medical education. Professor Phil, as a physician, who has moved from the bedside to the boardroom, you have seen health systems from both ends. In your experience, how do we ensure that the push to teach social medicine and health equity in our institutions does not remain an academic exercise? And what responsibility do university leaders carry in making sure that what we teach is actually reflected in how our health systems are built and who they serve?
Gosh, thank you. You had to take a deep breath in asking that question, didn't you? I think it's three things. I'm going to give you essence, presence, and incense. Essence. I think it's about us connecting with what the essence of medicine is all about, what the essence of medical education is, what the essence of medicine as a vocation, as a service is all about. We so often get caught up on hierarchy and bureaucracy. I spend my whole life being called VC or Prof. And actually what I really want is to be recognized as a human being, to be called by my name. And you see, that vice chancellor stuff, that professor stuff, that's a social construct dreamt up largely by men. And what we've got to do is actually break down that stuff, because Vincent is actually my line manager in the academic department of social and community medicine. And you know, when I go out teaching, when I go out on community visits with Sandra and Grace and others, you know, I have to sit on the floor. I don't get special privilege or special treatment. What is the essence of medicine, the essence of the service, of the vocation? And then we can make sense of social medicine. Because one of the things that marks us out as healthcare workers, as people who commit to the service of other people, is presence, is being there, is humbling ourselves to sit with some of the smelliest, dirtiest people that we might have to be with. Lionel Green Thompson is one of my most recent inspirations. I've only met him fairly recently. And somehow I think, and now yourself, sir, and sometimes think of anesthetists sitting at the head of the bed in an operating theatre, not having much to do with a patient, but being ever present. It's our presence, our walking alongside, our being with that makes sense of social medicine. And the final thing is incense. To be incensed, to be angry about the injustice that we see in the world, and to hold that anger, that righteous anger, and let that anger drive and make sense of social medicine as a powerful force within our medical schools, within our research portfolios, and within the way that people learn, and within the way that we improve the lot of people who we're truly called to serve. So if you understand, if we all understand, if we all agree on what the essence of the practice of medicine is, that we all understand the power of presence, of being with people, of living their lives with them, and we always remain angry about the injustices that we see in the world, then social medicine, you know, ladies and gentlemen, makes all the sense in the world. I hope that's okay.
Thank you very much.
Thank you very much, Profil. That was so inspiring. The essence and the power of presence and the incense. I hope you take that home. Yes, so we're going to open this discussion to the audience. Yes, we've heard from the experts here, but I know you have different experiences from where you are educators or from where you've been clinicians. So we're going to open it for a short time for discussion. And so if you have a question, if you have a reflection, and if you have an experience that you want to share of what has worked or what hasn't, so it's the floor is open. If anyone has okay, can I get the microphone? I'll first get two people. Yes,
Okay.
sir. And then back there. Yeah.
Thank you very much. I think this is very interesting discussion. Yeah, I think social medicine should not stand alone because it should be integrated in all which are teaching in family medicine, in community medicine, and even in any history. There is a part of social history, and this is not emphasized. If we see in Africa, our problem all from social problems. It is our disease, endemic disease, malnutrition, anemia, everything, even our mental health, our productivity is from social problems. It's not from, I think should go to detail social history. Should not be like European, just talking about family, talking about other things. I think we should details social history in place that can address our problems. Because without addressing these problems, endemic disease and other disease, we cannot do anything. Okay, thank you very much.
Thank you for all that we have seen today. Let me introduce myself. My name is Didier Kamatari. I'm from Burundi. And I assume that we are all Africa, but I assume also that we have some heterogeneity. And I am one of, Burundi is one of the different Africa that you know, actually. Why? Let me give my experience about what I know about social medicine. There was a question asking when we say social medicine, social determinants of medicine, what comes to our mind? For me, there was one name that comes to my mind. I didn't share it. I'm sorry. I would like to share it vocally. Che Guevara. I have an experience in medical practice from 2008. I begin as a GP in a center of Burundi, Gitega. We call the center Mutoi. I know there are some guys around that knows Burundi, like Dr. Eyand, I know him. They have a project at Kigutu. Mutoi has the spirit as Kigutu spirit. But the times I was there, and I'm very happy that I don't know your name, but I was happy that you said we were taught to learn about the history, background of the disease, but not background of the social. And the times I was there at Mutoi, the people there didn't speak French. They didn't speak French. They speak Kirundi. And the history was given in Kirundi. But I had my knowledge in French. The symptoms was in Kirundi. Let me give an example. In radiology, we thought that there was a sign. We call it in French, I don't know how we call it in English. We call it image Antonio de Pomme. I think you all know the apple. When you have already finished eating apple, there are those one who remains. That image, when I'm teaching my students, it's not easy for me to describe it in our Kirundi culture. But there, people, when they are talking about symptoms, they talk in their way. We have what we call, I have umusipa. We didn't know what is umusipa. Umusipa, it's a hernia. Fisagasu. Agasu is the area. For me, it was not easy to understand what does it mean. And there was a lady, an old lady, told me that I have like a kind of ghost, ikisigo, a ghost that touches me when I'm going to sleep. I don't feel I can sleep. There is a ghost. In his belief, she think about me giving him like what we call in Kirundi umupfumu. We give him like some kinds of remedies. This is the story that I have met in Mutoi. At that time, I feel like I am a poor man, as I don't know how to help that lady. And then I think about going back to school. Going back to school for specialize myself, I didn't find an answer. That's where I come to my question for all the audiences. So now I have the spirit of helping the new generation trying to integrate those aspects of social accountability in my country. But I'm facing people that they don't like it. And you know, I don't want to become a Che Guevara. Che Guevara died. He was a martyr. But I don't want to become a Che Guevara, actually. How can we do to implement in a such context as Burundi? Thank you.
Thank you so much. We're going to take one last person.
Thank you very much. My name is Professor Suleiman Hussein. I'm a dean of Nile University in Sudan, Khartoum. Thank you very much for addressing a very interesting and very essential and very important topic, actually. I am a surgeon, by the way. I'm a GIT surgeon. But I think that the problem goes down to the way we are teaching the basic clinical skills in history taking. If we are teaching our students that they have to go straight, as I mentioned earlier on, that you ask the name, the age, and then you go where do you stay, and then you immediately go to what is wrong with you. I think what I am teaching my students, that here, where do you stand before what is wrong with you? Where do you live? How did you come to the hospital? Who is at home? From how do you earn the travel expenses? And so on. So this is an essential part of the history which has to be taken very early before we go for the clinical symptomatology and signs of disease. Because now we are talking about personalized medicine. My understanding for personalized medicine, not on the genetic basis, but on the social basis. A lady with gallstones who comes for surgery, she may be treated differently who is having 7 children. Nobody to look after them at home when she comes for surgery. Her husband is earning money on daily basis. When he comes to the hospital with her, he may not find any income. is different from a lady who is living next door to the hospital and who is coming with a fabulous car attended by very well supported families. So this is a bread and butter of surgery. Surgery is not teaching them, it is not opening or removing organs. Actually, it is the important thing to apply the social competencies. Actually, when we talk about integration, we are not talking about integrating social medicine in each subject. We should integrate social medicine in any clinical scenario you encounter, whether in obstetrics or in surgery or in oncology, etc. I think this is the fundamental teaching purpose has to change. And this is what is going to make the change in our products of medical schools. Thank you very much.
Thank you very much. One last person, and then we end.
Thank you very much. I'm Professor Bello from Nigeria. I'm the Provost College of Health Sciences. Now, I'm also a community physician. We're talking about social medicine. Social medicine is not, okay, I think it's the mic. I'm Professor Bello from Nigeria. We are talking about social medicine. To us in community medicine, social medicine is not alien. It's part of our curriculum. I think the problem we have as clinicians, and maybe, let me say clinicians, is that we don't put emphasis and importance on our community medicine postings. We take them, in fact, they call us doctors without borders. You understand? But this is part of our curriculum. And students go through our postings. So if we lay importance on preventive medicine and we put importance to it, not, you see, clinicians, you don't play down community medicine. Don't play down social medicine. Don't play down preventive medicine. Because if you have enough strategy to prevent medicine, enough public health services and activities, we will have LD community. So I just want to encourage us that this is not alien to us. Social medicine is part of our curriculum. Let us build it, let us support it. When they learn it in class, when they go to the field, that is where they practice. And that is where they express what they have learned. Then when they come to medicine, they come to surgery, ENT, obstetrics and gynecology, whatever they have learned, that is where they practice it. And that is why it is being entrenched or established. So I want to emphasize that we put interest in preventive medicine, in community medicine, in all our institutions. And we will see that issue of social medicine will be is part of our curriculum already. It's not something we are bringing, it's not alien. It's just to encourage it. Thank you. God bless you.
Thank you all. I understand that we have different opinions, and let this call you to keep the discussion outside of this room. Actually practice this, talk about how we can do better, not only in this room, but even outside. Thank you very much.
While we are coming to an end, you see I have changed the mic, so something is different, right? I need to make sure the setting, when the setting changes, you get it. So I want to teach you something. We're learning, right? So it's a special clap because we have someone to appreciate today. So it will be wind to thunder. So we start with wind. Hey, we are learning. So we go together. Thank you very much. Wind. Then drop. 2 drops. 3 drops. 4 drops. Rain. Thunder. Thank you. So we want to dedicate this special clap to Mrs. Grace Iriza Ndatinya. Please rise. She is the mastermind behind this session, the coordinator, and why we got everything smooth. So one last time before Central comes, let us appreciate a wind. Drop. Rain, thunder, So, as we take my
As we come to the end of this session, we are lastly going to call Dr. Sandra Isano, who is a faculty at UGHC in the Department of Social Medicine. So as she gives us a word of closing, thank you.
Hello, don't leave yet. And thank you so much. You all are great people to still be here with us. I know it's lunchtime and we are running a little bit behind the schedule, but I am here for us to really craft together the key takeaway message that we should go with. And I want to bring us back to the question that we started with. Remember, from the symptom to the systems. How do you train a healthcare professional who is able to see and respond to the social realities that shape health? So over, I guess, more than 120 minutes, we've been discussing about social medicine, and we have seen it in action. We began by framing social medicine as an approach to medical education that goes beyond practice and that goes beyond the theory and enter in practice. And we have seen this brought to life through the role play, where the routine clinical encounters, they open deeper conversation. You remember the conversation, the group that was doing the role play talked about, the conversation into the child nutrition, the role of family support in a woman's pregnancy, but also the complexities of financial vulnerability. And again, this, perhaps for me, what stood out was that the clinical presentation was only the entry point. The real learning started to happen when students were asking questions about what are the things that are happening in people's life. And that is the shift that social medicine demands us, to go beyond, to ask those questions. And perhaps you have seen that students are actually capable of this new way of thinking when we create space for that, when we allow learning to take place in the community, when we value reflection and the lived experiences. We begin really training a doctor, a healthcare professional who is able to now think beyond the clinical presentation, who is able to say that, yes, this is the clinical diagnosis, what else is happening? But again, when I look here in the room, I really get excited. I'm excited because this is not isolated work. We are all here to do this work together. Yeah? The ball is in our court. And we have the ability to actually shape the clinician we want and the Africa we want. So at the UGH, we are interested in beginning a continental movement, the community interest in social medicine. The colleagues in the IT, they will put up a slide with the QR code. If you're interested in joining us, please, yes, yeah, it's right there. Please screen it and fill out information. It's very confidential. We'll be in touch so that we can continue to do this work together. So again, as I wind up, I really would like to say that to me, this is not the end of the session, but it's the beginning of deeper collaboration and shared learning. And as it's been mentioned by different people who have talked here, if we want to train a physician, a healthcare professional who we look at a person holistically when treating, we need to move from training about communities, instead train with the communities. So I will end again with gratitude to you, Grace, for crafting this. And yes, a round of applause. To also the speaker, Dr. Vincent, thanks so much. And the incredible people who participated in the role play. And of course, everybody in our department who did work to see this through, and everybody who has been behind this conference. We know that there has been a lot of work. People have worked above and beyond to see this through. So we say thank you so much. The IT team, the comms team, thanks so much. Let's have a great afternoon. Thanks. Oh yes, our department, please come forward. Everyone, I'm being too selfish. Please come forward.
Please come.
Hello, how are you? Abadini bose basohotse none se mwese tugafata ifoto yanyu aba MC mwambaye neza nge tugenda bari abantu bari gufata amafoto.